Cystocele is basically a misnomer. It is a defect into anterior vaginal wall, basically, and there is no defect in a bladder, problem in a bladder per se. As it sounds when we say the cystocele, the symptoms are because of number 1 is because of the vaginal mass, and number 2 are the urinary symptoms. Most of the time there is avoiding difficulties, but at times it can be incontinence too, and there is no problem in the bladder. Despite the patient complaining of urinary symptoms, and at times bladder need not to be touched here. Just the repair of anterior vaginal wall will correct the defect as well as the symptoms. Now, what are the causes of cystocele? Basically, it has the supportive tissue around the anterior vaginal wall, which can be due to the weakness, because of the undue stretching, and can be laxity, maybe due to childbirth, which gets exacerbated, and by the low level of estrogen in menopause. However, we can divide the cystoceles into two parts. The types of cystocele is lateral cystocele and central cystocele. However, according to me, clinical important are the two types of cystoceles, and either it can be a natural cystocele or a central cystocele. Natural cystocele, as many of us asking, is actually Nemites natural, that is a lateral cystocele, the term which we use day-to-day practice. But if you want to correct the word, actually it is a paravaginal defect. So lateral cystocele is nothing but a paravaginal defect. I want to keep these two pictures in mind, or if you want in a back to watch these pictures again, because the entire concept of vaginal cystocele and a central cystocele, these two pictures are important. Why we need to differentiate a lateral cystocele from the central cystocele? The reasons are 5. And if you can understand these 5 reasons, trust me, you would have learned everything about the cystocele. The difference isn't because of the age at the patient presents, but also I tell you what is the clinical significance. Why we need to differentiate a lateral cystocele from the central cystocele. The one of the cause, maybe this is the most important thing to understand. So lateral cystocele basically is formed because of the injuries sustained during childbirth, and especially when the tissues get detached from the white line. So when the tissues are detached, there is a bulge in the anterior vaginal wall, but it's not because of the laxity, but remember, because it is of the detachment, and detachment can be on the one side, can be on the other side, or can be on the both sides. It can be on one side, on the other side, that's why natural. Cystoceles are more likely to be asymmetrical in their appearance, and while the central cystocele is mainly because of attenuation of endothelial fascias and the supporting tissues. So understand it like this: the muscles are attached to the white line, however there is a between the tissue a become a free and thin, because this part is the dependent portion, and entire tissue bulges out like a balloon, and this balloon is caused by there is no asymmetry. The bulge is totally symmetrical, and because of the bulge or the ballooning of the tissues, there is a loss of their activities in the interior vaginal wall and over the cystocele. Look carefully at the picture. Now see this beautiful picture. This beautiful picture demonstrates the first picture is of normal vagina. You can appreciate the normal vaginal canal and the black colored is the vaginal wall entirely and laterally. Now when the central cystocele happens, there is an endopelvic fascia attenuation and the attachment is still attached on the both sides of the white line. However, there is a central bulge in the inferior vaginal wall. However, as you can see in the natural cystocele, because both the attachments are there at the white line are broken, so the entire vaginal wall is sagging into the vaginal cavity. So now we will also appreciate the fact that the breakage from the white line of the muscular attachment will happen whenever there is a sudden vigorous force, and that usually happens during the childbirth. So there is a group of women who present early, and that's important for gynecologists. A young age means less than 50. These are the women who present in the age group of 30 to 50 years of age and usually will have a lateral cystocele. However, the central cystocele is because of the weakness or attenuation of the fascia, which happens due to the loss of estrogen and weakness of the tissues, and it usually occurs in the late age or the older women who is presenting with a cystocele is on examination. We'll be able to differentiate between whether it is a lateral cystocele or a central cystocele. I hope you will understand now. If you have just forgotten, just go back and see the line diagram that if the rugosities are there, it is a lateral cystocele, and if it's a smooth, then it's a central cystocele. As the detachment from the white line can be on the either side or the both sides, and the lateral cystocele can be symmetrical or asymmetrical also. While the central cystocele is always, because of the generalized laxity and the weakness of the inhibitions of the tissues, they are usually symmetrical and smooth. There is another case, if people do not differentiate between the two kinds of cystoceles, they can put a sponge holder, or also known as a ring forceps, we can use, and these ring forceps you can put it on the two lateral fornices, and so you can act like a attachment of the white line is again and tell the patient to cough. And if the lateral cystocele will be there, it will be get fixed and there is no bulge. However, the central cystocele will still be bulging there. However, I do not prefer doing this type of test routinely, because I feel if it's not a good idea to see like this, and if we are able to see it directly without using the instrument inside the patient's vagina and open it, the cause for embarrassments and distress to the patients. Now it's $1 million question that why we should classify the cystocele, and does it really changes the clinical significance? The answer is yes, definitely it is so. As much as the simple part is concerned, that the simple tissue plication and a pubocervical fascia applications is enough for the case of central cystocele. While for the lateral cystocele, it is not enough. Actually and theoretically, in lateral cystocele, you have to take the paravaginal tissue and attach it to the white line, which can be done either by the vaginal route or open or by laparoscopically. However, these procedures are not very easy for everybody to do it. So ACOG, American College of OBGYN, according to it, it recommends that even a sacrospinal fixation, which is actually a continuation of the white line, can be used to correct the lateral cystocele, and that is very good. But when we use mesh to treat the prolapse, in the middle arm of the mesh is not came through the white line, and it was very good to kind of repair method for the paravaginal defects. But however, fortunately or unfortunately, in our country, we are not having that pleasure or luxury to use mesh in the patients of the cases of prolapse. So we can just forget about it, and let me tell you that this was the one of the easiest and very good way to reduce the paravaginal defect, and it is not just about the surgical treatment part, but it has a differentiation. The differentiation in the lateral cystocele has much more clinical significance as far as its wholesome treatment and management plan is concerned. For the lateral cystocele, the first thing is prognostication. As you know, that the patients who present with the lateral cystocele are basically the younger in the age and have tissue problems. So the tissue is broken. So they must be given the complete chance and a guarded prognosis as compared to the women with the central cystocele. Here the recurrence chances are much more with the lateral cystocele, and they have a long time for the lifespan survival, and you must give them a guarded prognosis and re-emphasize the importance of the pelvic floor muscles training to them, and how to activate their exercises, and how to exercise muscles, and what are the chances of recurrence and how it can be minimized. FMT is very, very important, and that should be pelvic floor muscles training should be considered for the lateral cystocele if you want to prevent the recurrence. And these are the young women, so will nicely compound all the pelvic exercises and the training they will learn. It should be revised properly, and it's a truly conservative management for them. The only conservative management means you can do it, and others specially. So you have to remember that when there is a detachment, and that does not, the lateral cystoceles are more helpful to contain the tissue inside. However, in the central cystocele, because the pressure is from everywhere equally, and the chances of failure of PFMT is very, the role of conservative is very less, because and the management is a very simple plication of the pubocervical fascia, and that management is very good for them and it's a good result. So less PFMT to the central cystocele than the lateral cystocele is recommended. And the sacrospinous fixation, ligament fixation, is more required for the lateral cystocele than the central cystocele. So simple plication repair for the central cystocele, and for the lateral cystocele, sacrospinous fixation is important. Thank you so much.